Good morning, ladies and gentlemen. Today is my last lecture on clinicopathological correlation. I hope you find my previous talks helpful in understanding the dermatopathology of different clinical scenarios. I am Professor Asher Ahmed Mashood, and I would like you to join and subscribe my YouTube channel for more informative dermatology teaching videos. You can follow me on my Instagram by taking a picture of this QR code. So the learning objective, as mentioned in previous two lectures, are to understand the various clinical features that correlate with specific histopathological appearances, and when it is indicated to take a biopsy and what to expect in a biopsy if you are deciding that you must diagnose or must investigate this patient. Before I discuss the clinicopathological correlation, let's revise the basic histopathology. Starting from stratum corneum, which is in the form of a basket wave in a normal epidermis. Then is stratum lucidum, which is a dense layer which is present on palm and soles. Then comes the major portion of the epidermis, that is stratum spinosum, comprising of keratinocytes, which are polygonal in shape and they are attached to each other with desmosomes. Then the last layer is stratum basal, comprising of keratinocytes and melanocytes. The keratinocytes are mainly columnar in shape. After that, there is the dermis, which comprises of almost 70% of the epidermis and the dermis of the skin, of course. And the dermis comprises of, again, two layers. The upper one is the compact layer, in which the collagen is compact, but it does not contain any adnexal structure except a few blood vessels. This is the papillodermis, and the lower portion of the dermis, which is comprising of almost more than 90% of the dermis, is the reticular dermis, in which collagen bundles are relatively loosely placed, and this portion contains all the adnexal structures. So the first clinical term I am going to take up today is the hypopigmented lesions. So from the childhood till old age, you will come across several patients in your OPD who have come to show you for a hypopigmented, one or many hypopigmented patches on their face or on the body. So by patch, you must all know that the lesions have no thickness. So they are flat lesions with altered change. And in this case, the change is depigmentation or hypopigmentation. So you can see this, a typical young boy on whose face you can notice several hypopigmented patches, which are not well defined, some of them showing a little bit of erythema. So this is a very common condition called as pityriasis alba. If you should not take a biopsy in such case, but if you happen to take a biopsy by getting it confused with vitiligo, you will find a normal epidermis with normal melanocytes, normal pigmentation. So despite of this hypopigmented nature, there is no disturbance whatsoever in melanocytes or melanocytes function. So this is a DOPA reaction in which the melanocytes are highlighted. So this is just a kind of eczema, and it resolves by giving topical corticosteroids or just moisturizing creams. Then this is a rather a depigmented lesion. The typical feature of the lesion is its geometrical configuration. It has several conical projections. The lesion is not convex. And if you take the history is prolonged, and the patient is having the lesion since quite some time without having any new lesion. So a lesion which has a long history, no and solitary with irregular outline is nevus depigmentosus and not vitiligo. And again, if you take a biopsy to confirm whether it is nevus depigmentosus or vitiligo, it will also have a normal histology with normal looking melanocytes and normal melanogenesis. Now, this is a case in which you find multiple depigmented lesions. The lesions generally have convex outlines, and this may have early onset or may have a late onset and has a tendency to spread. So, this is vitiligo. Now, if you take a biopsy of such a lesion, you will find typical absence of melanocytes at the basal layer. So melanocytes are absent, and if to further confirm, you can order a DOPA reaction or S100 reaction to confirm whether melanocytes are present or not. But they are absent in patients of vitiligo. Then comes another interesting scenario in which the patient has these typical white lesions. And if you do a dioscopy, you will find that the rest of the skin would blanch. And once you remove the pressure, the skin would revascularize, but these lesions would not. And further demonstrated by scratching the lesions, you will find that the skin surrounding the lesion, the normal skin would develop a little bit of erythema, while there will be no erythema in these white lesions. So these lesions typically remain unchanged, and this is nevus anemicus. And nevus anemicus is because of the increased sensitivity of the localized blood vessels to catecholamines, leading to vasoconstriction, as a result of which there is some degree of decrease in blood flow in these areas. So this is actually because of vasoconstriction, blanching due to vasoconstriction. So on histopathology, you will find a mild perivascular reaction, lymphocytic reaction around the blood vessels. This is another scenario, and you will come across such patients almost every day. So these lesions are not always hypopigmented. They can be hyperpigmented. They can be brownish in color. So there is a color variation in these lesions. The typical distribution is on the trunk, on the upper back, and on shoulders, and maybe in upper arms. So this is a fungal infection called as pityriasis versicolor. You don't need to take a biopsy, it's quite obvious. But if you require to take a biopsy by confusing it with some other condition, then you will find this typical spaghetti and meatball appearance in the stratum corneum. These spores, fungal spores or pseudohyphae, can be further demonstrated by ordering silver stain or by PS stain. Now, these are really confusing lesions. There are multiple hypopigmented but not depigmented, irregularly irregular bordered lesions present in young patients as well as old patients. They are not fitting with any other diagnosis with hypopigmented or depigmented lesions. You should suspect hypopigmented mycosis fungoides in this case, and this condition is fairly common in young individuals as well. So usually we consider that CTCL or mycosis fungoides is an old age disease, but hyperpigmented variety of MF is seen in young individuals as well. If you take a biopsy, the biopsy is that of typically of mycosis fungoides. You will find typical atypical lymphocytes going into the epidermis, demonstrating the phenomena of epidermotropism. In addition, there will be loss or degeneration of melanocytes in these areas as well. So the second clinical scenarios we are going to discuss today are the patients presenting with pigmented lesions. So the pigmented lesions, like hyperpigmented lesions, can be of different shapes, sizes, location. So the first and foremost, the most commonest pigmented lesion or pigmented macule or patches we see from the young age are the freckles. Freckles are just because of type 1 or type 2 skin and exposure to sun rays, leading to increase in basal and suprabasal pigmentation. So the histopathology will be very typical. There will be no change in the morphology of epidermis or the retiridges, but there will be increased pigmentation of the basal and suprabasal layer, which is quite obvious in this picture as well. So, in comparison to this presentation, clinical presentation, there will be other lesions which are typically seen in old age, which were not present before, and these are irregularly displaced pigmented macules and patches on the face, and these are actually the solar lentigens. The lentigens don't have any association with sun exposure and can develop on the face as well as on the body. But the solar variety of lentigens or the solar lentigens are typically present on the sun exposed areas. And these are the lesions which are the precursors of seborrheic keratosis later in the life. So these lentigens, if you take a biopsy from any of the lentigens, you will find two things. The elongated, irregularly positioned or shaped retiridges, and increased basal and suprabasal pigmentation like freckles. So this picture is different from freckles in only that there is a hyperplasia of epidermis with irregular projections of retiridges. Rest, it is similar to the freckle in having increased basal and suprabasal pigmentation. So if you do a dermoscopy on lentigen, you will find this pigmented reticular network that corresponds to the increased pigmentation along the elongated retiridges as we see in the histopathology. So on dermoscopy, there is our pigmented reticulate network, and on histopathology, there is elongation of retiridges with increased pigmentation. This is a typical flat, pigmented macule or sometime a plaque, and this is a junctional melanocytic nevus. If you take a biopsy, you will find very well organized nests of benign looking melanocytes, which are typically located at the retiridges, but usually involving sides of the retiridges. So the nests you can see are really well organized in form of globules. So this globular pattern is also seen in the dermoscopy. If of these junctional nevus, you will find that pigmented globules or clots, which corresponds to these junctional nests of benign-looking melanocytes. Then this is a raised nodular lesion uh, deep in without any pigmentation. So this is sometimes you will find here in the lesions as well. So this is an intradermal melanocytic nevus. And on histopathology, there will be no junctional activity at the epidermis, and there will be nests of benign-looking melanocytes occupying almost the whole dermis. The superficial nest will display some degree of pigmentation to give a clue that this is melanocytic origin of nevus, and the lower nest, that the nest down below the dermis will show neurotonization, which is the conversion of globular pattern of melanocytes to spindle pattern, just like we see in the nerves. This is a typical red papule or nodule in a child. And if you find such a nodule solitary in a child, the first diagnosis that should come in your mind is that of a Spitz nevus. If you take, you will not take a biopsy, you will remove the whole lesion. And if you remove the whole lesion, you will find a typical wedge-shaped morphology with some junctional activity of melanocytes as well as intradermal melanocytes, but everything would be very uniform and benign looking. If you find a blue dot, a papule or a macule, then the diagnosis again is quite straightforward. It's a blue nevus, and histology will show very heavily pigmented melanocytes which are present in the dermis. The melanocytes are mainly of ribbon-like pattern in the blue nevus, and rarely they are in form of globules. So these will be occupying the dermis. It's an intradermal form of melanocytic nevus, so there will not be any junctional activity. Dermoscopy is also interesting, like the blue color of the lesion. Homogeneous blue pattern that is structureless is seen while performing dermoscopy on a blue nevus. Now, this is a lesion, which is a plaque that has several features. The first feature is it's a large plaque. Second is it has irregular color. They are brown color. There's light brown, dark brown, white areas, and increased blackish pigmentation is also seen. And it has irregular morphology. So this is atypical lesion, and you must biopsy it because it looks like malignant melanoma. So on histopathology, there will be a complete structural and cellular disarray or atypia. You will find atypical melanocytes in the dermis, in the epidermis, in the junctional nest, and also going into the dermis, which would show the vertical spread of the tumor. So the nest you can see in the picture are irregularly structured. They are irregularly disposed, placed. There is individual melanocytes seen in the epidermis, which is called as the pagetoid spread of melanocytes. And then there's lots of lymphocytes and inflammatory infiltrate. So you can see the first impression of this picture is a complete irregularity or disarray. So usually the tumors are picked up by this only feature that the picture would look like a complete disarray or disorganization. So here is a comparison between a typical benign looking uniform nests of melanocytes and the irregularly placed, irregularly shaped melanocytes in malignant melanoma and irregular nests of abnormal melanocytes. These are the two different patterns of dermoscopy in melanocytic malignant melanoma. In the first pattern, you will see there are multiple atypical globi seen on the periphery and typical blue veil, which is seen in the center, which is quite typical of malignant melanoma. So in the lower picture, you can see that there are three colors, but rather more light brown, dark brown, blue, and black. And then there are dots and irregular reticulate pattern, as well as there are blue veils. So this is a thin malignant melanoma. A red nodule, not bleeding, typically seen on sun-exposed area in type 1, 2, or 3 skin. So this is a suspected melanoma, but this is an amelanotic melanoma. So amelanotic melanoma will not have any pigmented network or globules, but you would be picking it up by the structureless white or blue areas, the blue veil areas, the scar-like depigmentation, then lots of different kind of blood vessels, the irregular linear vessels, the hairpin vessels, and the dotted vessels. Some pigmented globules are also seen. And again, a nodule. Now, this nodule is deeply pigmented. And this could be a nodular melanoma. Nodular melanoma can arise de novo from an existing melanoma, but it can be a result of metastasis from some other site. So the nodular melanoma will have a large nest of atypical melanocytes in the dermis, which is expanding, and the epidermis making it stretched and thin, but there will be no junctional or intraepidermal melanocytic activity. This is how a nodular melanoma would look like, a nodule with irregular pigmented globules. There is no reticular network. There are blue and white areas, scarred areas, blue veil, and then some blood vessels, irregular. Now, the third scenario I am taking up today is that of lesions that showing sclerosis. By sclerosis, we mean that the skin is tethered up to the lower dermis. The epidermis is tethered to the lower dermis. And on palpation, it is thick and taut, and you would not be able to pick up the folds. So this is a typical sclerotic patches or plaques on the body. There can be one or multiple. The clinical impression is morphia. If you take a biopsy, you would see the epidermal atrophy with loss of retiridges. The dermis initially is thick with some hyalinized collagen and typical absence of adnexal structures. Later on, the dermis also becomes thinner and atrophic. A very similar sclerotic lesion, usually seen on the genital areas, but can be seen on other areas as well. The most typical clinical features here are the presence of follicular plugs. Multiple follicles are seen in the lesions, which appears to be plugged with keratin debris. So this is a kind of clinical sclerotic lesion with overlying keratotic follicles is typical of lichen sclerosis et atrophicans. On histopathology, there will be few features which are significant and prominent. The first and foremost is the follicular plugging. Then there will be epidermal atrophy. There will be zone of sclerosis or structureless dermis. And here, not seen here, but in early stages, there is a band-like lymphohistiocytic infiltrate as we see in lichen planus. And in inflammatory phase, there will be basal cell degeneration as well. That is why it is called as the lichen sclerosis. So here in this picture, there is only sclerosis and follicular plugging seen, and this follicular plugging will make it different from the histopathology of morphia. Another sclerotic lesion. But here, the prominent clinical appearance is that of arborizing of network of blood vessels. So this typical pattern has several nests of atypical basaloid cells disposed in rather thick and hyalinized stroma. So this is sclerotic basal cell carcinoma or morphiform BCC. Another sclerotic lesion. You can easily confuse this sclerotic lesion with sclerotic morphia, but here you find a typical border. This border is raised and irregular. You can see the border here. And if you take a biopsy of this lesion, including the border, you will find the corons. Sorry, you will find the conoid lamella here. This conoid lamella is band of parakeratotic keratinocytes, stratum corneum, parakeratotic keratinocytes in stratum corneum, which are invaginating the underlying epidermis at an angle. Now, the next scenario today is the vasculitic lesion. If you suspect a vasculitic lesion, what you will do a dioscopy. You will use either a glass light and will exert some degree of pressure on the lesions. If it is a vasculitic lesion or a purpuric lesion with blood in the dermis, it would not blanch. If it is an urticaria or eczematous lesion, it will blanch. So the first and foremost clinical tool is dioscopy to differentiate vasculitic lesion from non-vasculitic lesion. So the second thing you are going to do after dioscopy is to feel the lesion. If you cannot feel the lesion and it is only the altered color, altered redness or erythema, then it means that it is purpura and it is not vasculitis. So this kind of purpura, which we commonly see in middle-aged individuals on the leg, is Schomburg's disease or capillaриtis, pigmented purpuric dermatosis. So this is because of hypostatic circulation and is made worse by prolonged standing or sitting. On histopathology, you will find multiple RBC extravasation in the dermis, but there will be no element of vasculitis. Now, this is typical small vessel or leukocytoclastic vasculitis. There is purpura as well as the lesions are palpable. So another term is the palpable purpura. Histopathology is that of vasculitis. Most of the superficial blood vessels will show fibrinoid necrosis of their wall with surrounding lymphocytic and neutrophilic infiltrate, and they will also demonstrate lots of leukocytoclasia, that is breakage of the neutrophils, as well as RBC extravasation. The next term I'm going to take up today is the nodules on the shins, with or without ulcers. So by nodules on the shins or on the legs, the terms which come into our mind is the paniculitis. So the first clinical picture is that of several erythematous nodules on both shins. They are almost symmetrically distributed and they are quite painful. So this symmetrical distribution and multiple nodules excludes cellulitis. And this is typically erythema nodosum, which on histology will show a typical lobular paniculitis. So the paniculitis or the inflammatory infiltrate is surrounding the blood vessels, which are part of the septa running between the fat lobules. Erythema nodosum typically don't get ulcerated. So these lesions will not ulcerate and you can treat them well. Then these are a few images of several nodulo-ulcerated lesions on the legs. You can see here, this is a form of nodular paniculitis. Then here again, you can see multiple ulcers. The ulcers are of uniform shape, of symmetrical distribution, and have a pattern of self-induction. So this is factitious paniculitis. So all other paniculitis will give a dense, acute or chronic inflammatory infiltrate within the fat lobule. So these are the examples of lobular paniculitis. These are also the nodulo-ulcerated lesions seen on the shin with surrounding changes, which we call as the vascular changes or the changes due to the poor peripheral circulation, which include the purpura, include the irregular hyper and hypopigmentation, including the livedoid pattern surrounding the vessels, loss of hair in the surrounding skin. So this, if you take a biopsy, you will find three things. You will find two things. That is some form of paniculitis, as well as there will be deep vasculitis involving the medium or large vessels. So this is a medium or large vessel vasculitis, medium vessel, sorry, not large vessel, it's a medium vessel vasculitis. And the vessels are present either in the deeper dermis or part of the subcutaneous fat, and the vessel will show typical fibrinoid changes with surrounding neutrophilic infiltrate and leukocytoclasia and red blood cell extravasation. The picture shows multiple ulcerated nodular lesions on back of typical obese female. And clinical impression, in addition to polyarthritis nodosa, is erythema induratum. So erythema induratum is a form of tuberculite in which we find three typical features. The first is that it's a form of lobular paniculitis. Second is it's a granulomatous inflammation with presence of granulomas. And the third thing is that there will be the vasculitis. So it involves small and medium-sized blood vessels, which is the reason of ulceration present in these lesions. The next scenario for today is the solitary scaly lesion. There will be not much, there will not be many different conditions, but few typical conditions would come under this clinical impression. That is, the first is a solitary scaly psoriasiform plaque on hidden areas. So this is Bowen's disease. And Bowen disease is in situ sebaceous squamous cell carcinoma, and you will see a full thickness atypia on histopathology, and the atypical keratinocytes and lots of mitotic figures will be seen. Then similar kind of lesion is seen surrounding the nipple, and this is the clinical impression is straight away Paget's disease of the nipple, which is the cutaneous metastasis of intraductal breast carcinoma. And Paget's disease would give on histopathology would give an impression of multiple nests of atypical cells infiltrating the epidermis. The nests are small and large and is called as the Pagetoid spread, and the nests are morphologically different from the surrounding keratinocytes, and these nests are not connected with the keratinocytes by any sort of desmosomal junctions. So these two sets of picture on left side shows the Paget's disease with atypical Pagetoid cells infiltrating the epidermis singly or in group, while on the right side you see the Bowen's disease with atypical keratinocytes with abnormal mitotic figures. But you can appreciate that how, no matter how atypical the cell is, it is maintaining the desmosomal connection with the surrounding keratinocytes. Now, this solitary papillosquamous lesion is mainly seen on the face, and it is the diagnosis is superficial spreading basal cell carcinoma. On histopathology, the atypical basaloid nests with retraction artifact and is seen typically attached to the overlying epidermis. On histopathology, there will be various patterns. The most typical pattern is the presence of structureless white red areas. And in addition to, there are the maple leaf-like globules as well. On dermoscopy, arboriform vascular pattern is seen here on the right side. This pattern is typical of non-ulcerated kind of BCC, but where there is ulcer, this arborizing vessels break down to dotted, linear, or comma-shaped vessels. So the vessels will be well formed in the nodular basal cell carcinoma if there is no ulceration, and will be dotted or comma-shaped if there is ulceration. Non-inflammatory nodules or the tumor nodules. You can see this typical ulcerated nodules on a background of severe sun-damaged skin. There is a crater in between, so the confusion is between a BCC and keratoacanthoma and a squamous cell carcinoma. The biopsy is must, but the biopsy shows typical nodule of basaloid cells with the cystic degeneration, like you can see several cysts. So this is nodulocystic basal cell carcinoma. Has to be excised. Dermoscopic appearance is that of blue-gray ovoid nests. Here are the blue-gray ovoid nest, and dots correspond to small BCC tumor in the nest with telangiectatic blood vessels. So this arborizing pattern of blood vessel is quite typical of basal cell carcinoma. Again, a nodule with a crateriform ulcer in the center, and this is now keratoacanthoma. In a keratoacanthoma, you will find a crater filled with keratin. The surrounding epidermis forms claws around this crater, and the epidermis will show hyperplasia, epidermal hyperplasia, but there will be no atypia. Generally, the atypia is absent, and the typical feature is that the keratinocytes at the basal layer will form convex retiridges, but there is no invasion of the basal lamina. So this is a typical intraepidermal kind of growth, benign, self-resolving. If you take the biopsy, excision biopsy, then this is curative. And we can also treat these conditions with non-invasive methods like cryotherapy or cautery or CO2 laser. This is not a good lesion, a quite angry-looking nodular lesion with irregular pigmentation. It could be melanoma, it could be squamous cell carcinoma. You must take a biopsy. In biopsy, we find multiple nests of atypical squamoid cells with keratin horn cysts within the nests. So this presence of keratin horn cysts shows that keratinization is happening, and this is not very atypical lesion. So this is a well-formed, well-differentiated squamous cell carcinoma. A similar kind of nodular lesion is seen on the foot. There is history of long-standing viral wart, and this is carcinoma canaliculatum. It is an SCC of the foot with atypical squamoid cells seen in the form of nest in the dermis. Little keratinization, so this is mainly moderately or poorly differentiated SCC. This is another picture of poorly differentiated SCC. You can see, as I show you in the Bowen's disease, the keratinocytes are very atypical, but even the most atypical keratinocytes are demonstrating the desmosomal connections with the surrounding keratinocytes. The dermoscopic pattern of SCC is rather structureless white areas with surrounding pale areas. So there is no arborizing blood vessel, but rather blood spots are seen. So the typical structureless area is that of squamous cell carcinoma. Now there is another condition in which there is a rather benign looking nodule on the plantar surface, and you can confuse this with some carcinoma canaliculatum or SCC, but on biopsy it will show typical, well-formed, well-differentiated mini squames or cuboidal cells with clear demarcation with normal keratinocytes, and these are the poroma cells. And the condition is acrine poroma. Brownish, blackish, or skin-colored nodule, which on pinching go inside the epidermis, giving a dimpling. On histology, you will find epidermal hyperplasia with a Gren zone, that is zone which does not have any features. Then the underlying dermis shows well-formed nests of fibroblasts or spindle-shaped fibroblasts and histocytes. So this is a fibroblastic tumor. It is dermatofibroma, but it has also called a benign histocytic fibroma, and has lots of histocytes as well. On the periphery of the tumor, there is cutting up of the collagen bundle, showing the rounding up of or homogenized globules of collagen, which is also typical of dermatofibroma. Dermoscopy is quite similar to that of SCC, with a structureless white area and a peripheral network. So this white area corresponds to the fibrosis. Multiple skin-colored erythematous nodules present anywhere on the skin. This is not single but multiple nodules, and it is dermatofibrosarcoma protuberans. So there is no epidermal hyperplasia. The lesion starts just from the reti ridges and infiltrate deep into the dermis, even goes into the subcutaneous fat. And these spindle-shaped cells are arranged in storiform pattern or a rush mat or doormat pattern. You can see in this picture, there is a bluish color nodule on the face with some white areas. If you palpate, it will give a firm or hard look. Clinically, it is pilometricoma, and on histopathology, it will have two areas, the areas with basaloid or cells with large vesicular nuclei, or epithelial cells, and the inside of these nest shows the ghost cells, are cells with loss of nuclei, only the cell membranes are intact, and later on, calcification is seen within these areas. And as the lesion mature, this epithelial component of the tumor is also lost. So you would only see the ghost cells and calcium deposition. Skin-colored nodule is seen on the scalp. You can confuse it with nodular basal cell carcinoma or even pilar cyst. On histopathology, there is typical jigsaw pattern of nests, and these nests are comprising of peripheral dark and inner light-colored cells, which are derived from the acrine glands, and this is cylindrome. There is a nest, again, a nodule, which is seen. It could be anything, but the history is that of pain off and on. If you take a biopsy, you would see the typical capsule. In this case, these are the nests with a capsule, and there is not many adnexal tumor having the feature of a well-formed capsule. This is acrine spiroadenoma, and again, it has typically two population of cells, cells with dark basaloid nuclei, and the other one are cells with light color vesicular nuclei with cyst-like spaces. Bluish color nodules seen on the digits mostly. They are sometimes painful as well. And histology would show several blood vessels containing RBCs with surrounding nests of cuboidal cells, and this is glomastule. Again, a keratotic vascular nodule with history of bleeding off and on. Has an acute presentation. Histopathology will show several nests or lobules of small blood vessels or capillaries. So it is benign capillary hemangioma or pyogenic granuloma. So multiple small nests of small size blood vessels or the capillaries. Now we are reaching to the end of this talk. We are going to discuss the non-inflammatory papule or nodules, tumor nodules. But here in this, in following few slides, I am going to discuss those nodules which are present in abundance or multiple. So this is a typical keloid. You can see two keloid, one large, one small, and most of the individuals have multiple keloidal growths. And keloid will have a typical homogenized collagen bundles within the dermis. Epidermis is unremarkable, sometimes it is thinned. Then these are multiple skin-colored papules seen anywhere on the body, and they are sometimes painful as well. When we take a biopsy, you would find a typical cells with cylindrical shape, blunt edges, and this is leiomyoma. A soft pedunculated growth seen on background of multiple freckles and capillary macules, typically neurofibroma. This is one large and several small neurofibromas. You take a biopsy, you will find comma-shaped cells with comma-shaped nuclei or wavy nuclei or spindly nuclei, which are loosely dispersed in a stroma. This is neurofibro. Multiple skin-colored papules seen on the nose and on the nasolabial folds. Typical placement and location is that of trichoepithelioma. Trichoepithelioma has many similarities with BCC, but number one, these basaloid nests, they are not that atypical. They don't have a connection with overlying epidermis. The nest have peripheral palisading, but there is no retraction. And there will be several small to large keratin pearls, which are seen within these basaloid cells. Sometimes the collagen stroma is thick and dense. This is the desmoplastic variety of trichoepithelium. Multiple small soft papules under the eyes, again a very typical presentation of syringomas. If you puncture any of the lesion, you would find skin-colored fluid coming out of the lesion. And histology shows several small nests of ductal epithelium, small nests of ductal cells with ducts in between and tadpole appearance. The last portion is that of the lesions that appear cystic. One of the most commonly encountered cystic lesion is epidermal inclusion cyst or epidermal cyst, which is the misnomer of which is sebaceous cyst. It is not a sebaceous cyst. It is only an epidermal cyst with a typical lamellated keratin inside, and the cyst lining contains granular layer. Then this kind of cyst is seen typically on the scalp. Here, the keratinization is of pilar type, the homogenized type of keratinization, and the surrounding epidermis lacks the granular layer. This is a pilar cyst. The third kind of cyst, which we see in adolescents, young individuals are the soft consistency, cysts with soft consistency, and this is the typical sebaceous cyst or steatocystoma multiplex. Why they are called as cysts? They are, number one, they are soft, they are collapsible, and the sebaceous glands are seen part of their wall, epithelial lining. So here we compare the typical epidermal inclusion cyst or epidermoid cyst with the lamellated keratin, the granular layer, and the epidermis, and a sebaceous cyst or steatocystoma multiplex with a collapsible wall, a normal epidermis with granular layer, and sebaceous ducts or glands opening into the epithelial lining of the cyst. Sometimes these cysts or cyst-like structures can be many. So one of this condition is this, in which there are multiple small, large, different sizes, skin-colored, cystic lesions, papules. Again, if you puncture it, you will find a clear fluid, and sometimes blood is also seen. And this is lymphangioma circumscriptum. And similar kind of blood-filled vesicles or papules are also seen, and this is hemangioma. It can be congenital or it can be acquired. So this is the histological difference between a hemangioma on the left side and lymphangioma on the right side. The hemangioma will show dilated blood vessels with a thick vessel wall and containing RBCs, while lymphangiomas will show dilated vascular channels with a very thin endothelial lining and filled with serous fluid. So this brings me to end of this talk. I expect that this talk and all of my previous talks on clinicopathological correlation would have benefited you in understanding the histology of skin lesions more. Thank you very much for your patient listening. Goodbye and have a good day.